And we are moving on now to our third presentation by Dr. Corinne Hohl, and she will talk about the most important emergency medicine literature of the past year. Corinne is an associate professor in UBC's Department of Emergency Medicine, scientist at the Center for Clinical Epidemiology and Evaluation, and an associate member of UBC's School of Population and Public Health. She practices emergency medicine in Vancouver's VGH Hospital. Her main interests are in emerge, patient safety, health systems, innovations, and critical appraisal. More recently, she has been working on a national COVID-19 registry to help us develop evidence-based clinical decision rules to provide guides of COVID-19 treatment and management in the emergency room. Please welcome Dr. Corinne Hohl.
Thanks, Crystalia. Can everybody hear me? Okay, so what I thought I'd do is I'd pick up from Rand, talk about big people, and give you something about an age-old problem that we've been discussing quite a bit, but for which there's some recent evidence that's certainly influencing my personal practice. And we'll talk about something that is literally new, hot off the press from September of 2020. And then I thought I'd finish off with a little bit of something controversial, heading you off into the question and answer period. All right, so we'll review the papers and we will focus on adult literature for emergency medicine patients. I don't have any disclosures to declare. All of my academic work is funded by not-for-profit organizations. So let's talk first about something old. And I'm gonna ask you all to pick up your phones and go to menti.com. So www.menti.com. And if you type in the code 7788383, you should be able to submit your answer to this question. So the first case I have for you is a 55-year-old postmenopausal woman presents to your emergency department with pleuritic chest pain and shortness of breath. She doesn't have fever, she doesn't have myalgias, there's no history of trauma. The heart rate is 98, her vital signs are otherwise normal. She's not pregnant because she's postmenopausal. She's not on any hormones, and she has no known medical history. And your resident has actually already seen this patient, or your nurse has already drawn this blood work, and the D-dimer comes back at 859. The question is, what would you do? Would you discharge her? Would you order a CT chest to rule out PE, or would you order other diagnostic imaging? Excellent. And I love the questions coming in. You guys have obviously found Menti. Excellent. Well, it sounds like we have a strong majority vote for ordering a CT chest to rule out PE. So what I'm going to do is I'm going to go ahead and show you the latest evidence in this area. Okay. So Kieran et al. Did a multi-center prospective study in Canada looking at the diagnosis of pulmonary embolism with an adjusted D-dimer. We all know, or we all have in the last couple of years, accepted a standard of care that when we believe a patient has a low clinical pretest probability of disease combined with a D-dimer of under 500, we usually feel comfortable discharging that patient. However, to our chagrin, only about 30% of patients will meet those criteria, which means that we're doing a lot of CT scans of the chest. So what Kieran et al. Did is they developed a new strategy, which is a little bit of a spin-off of the year's protocol for any of you using that one, where they looked at the combination of a low clinical pretest probability of disease and a D-dimer cutoff of under 1,000, or a moderate clinical pretest probability of disease combined with a D-dimer threshold of 500. And they managed patients according to this protocol across enrolling centers in Canada. So there was no control group, but they literally discharged patients who met these two criteria without any anticoagulation, and they followed them up at 90 days for suspected symptomatic venous thromboembolism. And I'm going to just walk you through this slide. So they had over 2,000 patients here that were enrolled. And as you can see, most of these patients had a low clinical pretest probability of disease, and that was a Wells score of 4 or less. They did do a D-dimer test, as your resident or nurse did. And what they did is, if that test was less than 1,000, they discharged that patient without any anticoagulation, and they followed up that patient at 90 days. 0 of 1,285 patients had a symptomatic VTE at 90 days. Similarly, in the moderate pretest probability group, so these were patients who had a Wells score of 4.5 to 6. Fewer patients had a completely negative threshold and had a D-dimer under 500. So notice the lower D-dimer threshold to compensate for the moderate clinical pretest probability here. They discharged those and they had 0 venous thromboembolic events at 90 days. This is just another way of looking at their data. And I'm just going to draw your line here to these low or moderate clinical pretest probability patients that were combined with negative D-dimers. So under 1,000, you can see that there were 0 patients here that actually ended up having the outcome at 90 days. And among moderate clinical pretest probability patients and a dimer cutoff of 500, 0 met that criteria. And with that new algorithm, they were able to image only 1/3 of patients. So they quite drastically were able to reduce the rate of imaging compared to standard care. Now, the limitations of this study are that this is a convenient sample of consenting patients. I would be a little bit careful applying these data to patients who you don't think would participate in a study, quite simply because we know that patients who tend to volunteer and consent for this type of study generally have somewhat better health outcomes than if you enroll a cross-section of the population. They did lose a few patients to follow up, but really very few if you consider that the sample size was over 2,000. When they accounted for those losses to follow up and they assumed that some of these had PEs, the risk of symptomatic venous thromboembolism was still exceedingly low. And the one limitation or care, their caution that I would throw into the wind here is they didn't have as many moderate risk patients as low risk patients. So the point estimates here are a little bit less certain. But the bottom line is, for me, after reviewing this study, I certainly will probably apply this new D-dimer cutoff of under 1,000 to my low pretest probability patients. And so I would consider discharging the patient in the case that I presented to you with that D-dimer of 859 based on this new study. Moving right along, something new, something that I worry we're going to see a lot this winter. This is hot off the press. You see a 52-year-old male who signed up to your emergency department. This is a gentleman who has obesity. He also has hypertension. He's been to a wedding a couple of weeks ago. Unfortunately, he has a cough. He's quite hypoxic on room air. He's got a fever. You believe he has COVID. You have to wait for your PCR test, but you're starting to think about what types of things you might be able to give this patient. His chest X-ray does not show a focal consolidation. All right, you guys have been reading the literature here. So what I will say around hydroxychloroquine, just before I head into the literature, is that hydroxychloroquine is no longer recommended as part of any kind of clinical care pathway for COVID patients because of the risk of harm. And let's go over this study. This is an incredibly exciting paper. It's not only hot off the press, but it's a brand new study methodology. This is the first ever prospective meta-analysis that was done by the WHO REACT working group alongside these randomized controlled trials that everybody has been really working so hard to get through completion. They estimated the association between corticosteroids compared to usual care or placebo with 28-day mortality. So they did this meta-analysis alongside publishing the results of these RCTs. And what's really important for us, they didn't just enroll patients with confirmed COVID, they allowed clinicians to enroll patients with suspected COVID. And so only about 80% of these patients actually had COVID confirmed by RT-PCR. And this really reflects certainly my practice in the emergency department, where sometimes I'm going to be seeing a very sick patient with suspected COVID, but I actually can't get the diagnostic test back before I feel like I need to make some treatment decisions. Not all patients were intubated. A lot of these patients just had high flow oxygen and oxygen delivery of greater than 6 liters per minute. They looked at the class effect of steroids versus usual care. Over 1,700 patients included or contributed data to this meta-analysis, and a lot of these RCTs had really a low risk of bias, which is excellent news for us. And these are the results. So you can see that we have the most data on patients who were given dexamethasone. We have some data on hydrocortisone and very little data on methylprednisolone. So if I had to pick one agent, I would pick dexamethasone, which is good news because it's cheap and it's generic and almost everybody has it. As you can see in these diamonds here, this is the most precise point estimate, or the pooled meta-analytic estimate from the randomized control trials. And you can see that the point estimate for dexamethasone quite strongly favors the administration of steroids, and that effect is consistent across the entire class of medications. What's really important is that this effect it's robust across different age categories. It's robust for both men and women, and it's also robust depending on how rapidly that patient is deteriorating or the duration since symptom onset. Now, the limitations are that they did have a few patients in every trial in which at 28 days, the patient remained on a ventilator or admitted to hospital, so they couldn't for sure categorize the patient as having survived or not at 28 days. There were very few missing outcome data though, so that is somewhat reassuring. And the other thing that they had, and I think this is a reflection of this being hot off the press, is they had inconsistent reporting of serious adverse events across these randomized trials. But I would sort of counter that by saying we have a lot of experience with steroids. We generally understand what the risk of steroid administration is. So the bottom line for me in my practice certainly is, as for all of those of you who managed to log on to Menti, is that I would certainly consider giving dexamethasone as first-line therapy among COVID suspect or confirmed patients who are coming into my emergency department hypoxic, requiring more than 6 liters of oxygen. Okay, and a little controversy, and I'll speed up here. Now that patient is starting to tire, you've had him on CPAP, but that patient is now tiring and you now have to intubate. You don't have a backup, it's you. Okay, and I'm gonna cut this off a little bit sooner because I'm getting a 2-minute signal. We have one holdout for succinylcholine. Most people would transition to rocuronium. So this is the best available evidence on this data and the only large randomized control trial that we have. And because we're going to head into a season where I believe we're going to be intubating a lot of hypoxic patients that are on the very steep part of the oxygen hemoglobin dissociation curve, I thought this could be relevant. They asked the question, is rocuronium non-inferior to succinylcholine for RSI in out-of-hospital emergency settings? Keep in mind that succinylcholine was the standard of care up until recently. And what they did is they randomized adults needing intubation to either receiving 1.2 milligrams per kilo of rocuronium versus succinylcholine, and they looked at their first intubation success rate. These were all intubations that were performed by physicians, either emergency physicians, anesthesiologists, or intensivists in a mobile ICU. They enrolled over 1,000 patients, and unfortunately what they found was they did not meet their non-inferiority margin. So as you can see, they would have allowed up to 7% inferiority of rocuronium and still called rocuronium non-inferior, but their point estimate, the most precise estimate, favors succinylcholine. And what they found in terms of adverse events, they did find that succinylcholine was associated with a little bit more side effects, but interestingly enough, it's not at all driven by aspiration, it's driven by hypotension. They did have reports more commonly of ventricular tachycardias in the succinylcholine group, but they had a higher report of cardiac arrest in the rocuronium group. So lots of interesting data to think about, nothing conclusive in terms of their adverse event profile. So the bottom line here is there is a bit of a generalizability issue here. This was in an outpatient EMS setting with a lower first pass success rate than we would generally expect in a Canadian emergency department setting. But this is by far the best available data. The one thing they did not collect any information is about awareness. And that I'm aware of several lawsuits ongoing right now in Canada with patients intubated with rocuronium who had inadequate sedation, who were then paralyzed and awake underneath being paralyzed. So that was not evaluated as an outcome. The bottom line is, in this randomized trial, which represents the best available data, they failed to demonstrate non-inferiority of rocuronium with respect to first intubation success compared to succinylcholine. So for me, this is not a hill to die on, but I do think this is a call to our entire community to please use evidence and not eminence-based medicine when we are facing these important treatment decisions. If you are comfortable using succinylcholine, then I certainly believe that as we head into a winter where we may be intubating a lot of hypoxic patients and where the speed of intubation and that apnea period is really important, you may consider using succinylcholine in that context. And I'll wrap it up and hand it over to Crystalia for any questions that you guys might have.
Thank you very much, Corinne. Those are 3 fantastic articles to review. I have 2 questions so far. The first being, how does COVID factor into determining pre-test probability as well as criteria were not validated in the context of COVID?
It's an excellent question. I don't think we know. We don't have any data on that yet. So
Okay.
I don't think it does factor in. I think a suspect COVID patient you would have to manage according to your personal judgment. And I would have a low threshold to imaging these patients because we know that COVID is associated with hematological abnormalities.
Thank you. The next, in the PE study, how many of the patients went through the study actually had VTE?
That's an excellent question. Can I put the slide back up so that I can display the result? Because I don't know it by heart. Is that all right with you, Crystalia? I'm just going to bring you back to the slide here. And they had a pretty high baseline rate of VTE. Just a quick sec. Here we go. So you had 87 patients had PE on their initial imaging among the low pretest probability group. So that's a little bit more than 10%. And they had an additional 2 at 90 days. So that's about a 10% sorry, that's about a 5% rate. I'm sorry, I didn't do the math before this presentation. And then among the moderate risk group, 43 had PE on initial testing. And in the high risk group, they had 19. So almost not about 40% of them. So just doing the math really quickly without being able to quote the hard numbers, this looks to me like it's approximately 5%, 4 or 5%. In the moderate risk group, this looks like it's about 20%. And in the high pretest probability group, it's around 40%.
Thank you, Corinne.